Hey guys, welcome back to the channel Medic Junkies. My name is Dan. Today we're going to talk about some trauma management, specifically thoracic trauma. Now there's typically 4 things that you need to rapidly assess for and potentially treat. Those 4 things are going to be the things that kill these trauma patients, okay? So tension pneumothorax, tension hemothorax, pericardial tamponade, and of course any massive hemorrhaging. So we're going to talk about the products that we have on our trucks. We have our occlusive dressings. We also are going to talk about needle decompression and the needles that work, don't work, and the newest one that we just got. And we're also going to talk about how to manage some of that massive hemorrhaging. All right, so let's start with our tension pneumothorax or tension hemothorax. There's 2 types of trauma, penetrating and blunt. So if we have any kind of penetrating trauma from our neck to the pelvis, we're going to want to cover that with an occlusive dressing. Depending on your protocol and depending on what textbook you're using, the older approach used to be if it was an anterior chest, we would want to tape that occlusive dressing on 3 sides, leaving one side open. If it's the abdomen, the posterior back, or the neck, we're going to seal that up completely, all 4 sides of that dressing, okay? So let's just say that we have an open wound right here on the anterior left chest. First thing you want to do is take a gloved hand and put pressure on that hole, okay? The glove that's on your hand will help seal up that wound, preventing any more air coming from out of the patient and going into the pleural cavity. Meanwhile, you or another partner are going to go ahead and grab your occlusive dressing. So this is our old school traditional style that we would use. This has a petroleum soaked gauze that's inside of it, covered by this tin foil packaging, okay? So we're going to go ahead and peel this open. Go ahead and peel it all the way in half. And the petroleum gauze is going to stay stuck to one side or the other. Whichever one it's stuck to, we're going to use that one first. I've seen a lot of people try to peel the petroleum off, put it on the patient's wound, and then they just go ahead and cover it with the tinfoil anyway. That's a waste of time in my opinion, and your fingers are going to get real slimy with the petroleum, okay? So again, a partner has a gloved hand on that hole. I'm going to peel this open, immediately take this dressing. If there's any bleeding around, you want to take some 4x4s, a trauma pad, abdominal pad, whatever you can, wipe some of that blood away, and then we're going to immediately put this dressing over that penetrating wound, okay? The reason why we want to wipe all the blood away is we just want to make sure that our tape is going to stick, okay? Now, there's, again, 2 trains of thought. We can tape this one with 3 sides secured to the patient, or we can tape all 4 sides. So I'm going to show you the 3-sided tape technique first, and then I'm going to talk about how we can burp the dressing, and then we'll go ahead and do the 4-sided, and I'll talk about what our next step would be. So now we have this dressing that's covering the wound. My partner's going to grab me some tape. We're going to start with the 3-sided technique. You want really big, wide tape, and don't be afraid to go a little long with it. You can always tear off the excess if you need to, but I really want to seal this dressing up, and I don't want to cut myself short. So when I'm taping, I'm crisscrossing my tape. Again, just really making sure that it's nice and secured on there. Here's my 3rd side. Put some pressure on that, make sure it's nice and snug and sticking well. If you need more tape, throw more tape on there, okay? So the train of thought here with taping 3 sides is if I continue to have pressure building up inside my chest and I can see signs and symptoms that the patient starts to deteriorate, things like decreasing blood pressure, elevated heart rate, if they're becoming tachypnic and breathing a lot faster, shallow, usually you'll see the pulse ox dropping on the monitor, CO2 is dropping, lung sounds are going to start diminishing or even become absent. Patient might start becoming more and more cyanotic. These are all signs of a tension pneumo or hemo. So if that's the case and we've taped 3 sides, we're going to want to burp this dressing, okay? So all that means is I'm going to go ahead and peel this back. And in theory, any of the excess pressure that's inside the pleural cavity should be able to come out through that penetrating wound. Once we've released some of that excess pressure, we'll just go ahead and seal this back up, okay? Now again, most of the newer books and protocols are just going to say to tape all 4 sides, especially if you have a medic partner. We're going to go ahead and secure that wound completely, and then if we have to release any additional pressure, your medics can go ahead and do a needle decompression, okay? So we'll grab our 4th side, again crisscross all of our tape. If you need more, use more. If any blood is seeping through, try to wipe some of that off and then cover with more tape. The idea is that we're just completely covering that wound and we're not allowing any more air from outside the patient to work its way in and create any more of a tension with pressure on the lungs inside that pleural cavity. So again, this is what we had on our trucks. If you still have these, I would say keep them, but we have hopefully replaced all of them, or at least added these to all of our bags on every truck. So if you don't have these yet, this is the hyphen vent. Just make sure that you grab this one. So the Asherman chest seal, we're gonna go ahead and open this thing up. It's gonna have a 4x4 on here. This is designed to go over the wound first, kind of helps soak up any of the bleeding, so it stops the bleeding from coming through the sticky side of this dressing and preventing it from sticking. That is one of the downfalls to this, is they don't stick very well. So kind of got rid of it for that. But this has a whoopee cushion style vent on here. So the idea is that you cannot have any air come back into the wound and create any more of that tension within the pleural cavity. We're going to try to put this hole directly over the penetrating wound of our patient, okay? But as you can see, we kind of need to have a little bit of a smaller wound. If it's a big, massive wound, this thing's not really going to work so well. So 4x4 out. Again, we start with a gloved hand. We're going to go ahead and wipe off as much of that bleeding as we can so we can let this stick better. Take this 4x4, kind of put it right on top of that hole, and then we're gonna go ahead and open up our dressing. Just peels off like that. We're gonna take that hole, we're gonna aim directly for that wound, and then we just wanna make sure that this dressing sticks as best as we can all the way around the patient. And then the idea again is air is not going to be able to go in, but if air is building up and pressure is becoming excessive inside that chest, causing the patient to deteriorate, it should just kind of self-vent through this device. So this is the Asherman chest seal. All right, so now let's talk about this hyphen vent, okay? This is supposed to be on all of our trucks within our gear. Basically, this has two red spots here indicating where we want to tear this open, okay? So we're going to peel that right open. Pull this device out, and this thing is going to be sticky, kind of like an AED pad. Again, a 4x4 here. We'd have a partner first put a gloved hand right over that wound to seal up that wound while we get this out, and then we're going to wipe off any excessive blood with whatever bandages we have. It also comes with a little 4x4 here, so we can just put that right over the wound, and then we're going to peel this open. So as you can see in here, this basically has a very large circle right in the center. That's kind of the target that we want to put right over the wound. And then you're going to see 3 channels here that are not sticky, and that's the part that's going to allow air to escape out of here. Everything else is going to be extremely sticky on here. So kind of self-explanatory. Peel on that red tab. We've wiped off the excessive blood. We put that right over, and then we're going to want to put that center circle right over our wound. And then really press hard, firm, make sure everything is sealed up all around, and then we're good. Okay, so again, this is going to be the hyphen vent, typically designed just for a single penetrating wound. So if we had multiple, we would want to grab additional occlusive dressings. But for the single wound here, again, peel it off, put the 4x4 on it, hard seal across it, and air is going to push out of these non-sticky vents, preventing any kind of further air introduction into the pleural cavity. But if there's excessive air and building up and the patient deteriorates, air is going to work its way through that wound and vent out through these 3 channels. All right, so now we're going to talk about needle decompression. This is going to be for your tension pneumo or your tension hemothoraxes. Let's just first talk about the needles that we should not be using. So this is a 14 gauge peripheral IV. These needles are only going to be 1.25 inches long. So that's not long enough to get through all the layers of tissue through the pleural cavity and actually be able to reach that space to let the air out. So if you have these in your kit, in your airway kit, your trauma box, that you plan on using these for a tension pneumothorax, just don't. Get rid of them. They're not going to work for you, okay? What we need to use are these ARS needles that we have. Now remember, there should be multiples of these in all of our gear. And on your truck, it might be different. You might find these in your trauma box, you might find them in your airway box, they might be in that airway roll with the intubation, and you're definitely going to have some of these in both of those active shooter bags. So my recommendation is going to be, if you have any kind of shooting, stabbing, or you get PTI of a penetrating wound, I would recommend that you bring those active shooter bags with you, because you don't know how many occlusive dressings you're going to need for how many holes they might have. You don't know how many of these needles that you're going to have to use for your patient. You just want to be over prepared rather than under prepared. Okay, so this ARS needle, this is going to be a 10 gauge 3¼ inch long needle. This is kind of an older one that we've had for a long time. However, you've had some replacements here really recently. So this older one just has a single hole at the tip. The new ones that we have should say enhanced ARS needle. It's essentially the exact same thing. Still 3¼ inch long, still a 10 gauge. Difference is in the enhanced one, you're gonna have 3 additional holes along this catheter, okay? So what that allows you to do is get more blood out through this needle. It's just in case you have one hole or the tip that gets coagulated with blood and clogs, you're still gonna have additional holes that can continue to let this blood drain. If there's a tension pneumo, it's just gonna very quickly release some of that air pressure. So if you still have these, hang on to them. Again, you might need multiples of these, but just make sure that you have the new enhanced ARS needles as well. So let's talk about the locations that we can go for. There are 4 locations that we can needle. 2 on the anterior chest and 2 on the lateral sides of your patient, okay? Now, there's not anything that contraindicates any individual site. Of course, we want to needle over the site of the injury where we can release the air or the blood. But there is one site that is least preferred, okay? And that's going to be your anterior left chest. Reason why it's kind of not preferred is because there is a likelihood that you could hit the heart or hit the aorta. So when we measure our length out, we're trying to find mid-clavicular, right? And a lot of times when people measure that clavicle, they kind of stop short at the shoulder. Remember that clavicle extends a little bit into that shoulder. So what people have mistakenly done is they measure it short, they find their medial site. When they come down to that second, third intercostal space, they usually end up too medial than where they should be, okay? And that's where that risk of hitting the aorta or the heart comes in. So usually when I find my landmark, again, I'm gonna go from my shoulder basically to where I can find my end here of my clavicle, measure to the medial site. I'm gonna walk down 2-3 spaces in my intercostal spaces. And just to avoid hitting that aortic arch, I want to move one finger length a little bit more lateral on my chest just to play it safe. Okay, that would be my recommendation. Also, as far as going anterior versus lateral, we have a couple different things there. If you're still on scene and you're able to raise a patient's arm, I would say let's go lateral first, okay? If we have a tension pneumo that we're dealing with and we're trying to release air, it really doesn't matter where you go. Think of trying to pop a balloon. It doesn't matter where you pop the balloon at. If you stab it, it's gonna pop, right? Air is gonna get released no matter where you go. However, if you're dealing with the tension hemo, we typically have our patient supine, okay, being a level 1 trauma. Blood is going to settle towards the posterior side of your patient. So we wanna get a little bit lower and get on these lateral sides so we can actually drain the blood from the patient's chest. Now let's talk about our exact landmarks. Again, anterior chest, we're gonna measure the full clavicle, find that medial space, and we're gonna walk down to either our second or our third intercostal space. If we're gonna go to our lateral space, we're shooting for the 4th or 5th intercostal space. Most patients are gonna be a little bit heavier or they got a lot of like tissue. You're not gonna be able to walk your way all the way down and then come over on most patients. So a couple other ways you can find your landmark. If you are able to raise their arm up, you wanna look for basically the very bottom edge of where their armpit hair grows. Right at that line is essentially where we wanna go, okay? Another trick is that you can take your hand, assuming it's an adult patient and our hands are generally the same size, you can put your index finger up into that crest of the armpit, and where your pinky ends up is gonna be basically that spot that you wanna go. That'll be roughly the 4th or 5th space, okay? Now, traditionally, we were always taught to go mid-lateral on that line. However, if you think of the lateral side, there's 3 different planes here. We have the mid-lateral, an anterior lateral, and a posterior lateral, okay? In our protocols currently, they are actually telling us now to go on the anterior lateral side, okay? So just bring it up a little bit more towards the medial end than where we would traditionally go for a long time, okay? When we insert, we're typically gonna take our needle and we're going to find our landmark. We're gonna wanna kind of come at an angle and roll that needle over that rib, okay? I just want to ensure that I'm stabbing right above that rib. I don't want to puncture through the bottom end of a rib. Remember, on the bottom side of these ribs, we're going to have a bundle there. We're going to have nerves, arteries, veins, and we don't want to stab through that if we can avoid it. So again, I typically will essentially go at an angle, roll the needle over that rib, and then try to make my initial insertion, okay? So on this patient, again, there's my mid-lateral line. I'm going to come more to my anterior lateral line. I'm going to go into that armpit, and essentially, again, where my pinky ends up is kind of my target, or where that hair stops growing, okay? I'm going to pull out my appropriate catheter, again, the ARS or the enhanced ARS that we're getting now, and I'm going to find my landmark. Of course, I would want to clean it with some alcohol or betadine. Of course, I would have gloves on as well. I'm going to kind of start at a low angle, and I'm going to come up towards my 90. Okay, now I usually think of this as a two-handed approach. Okay, so I'm going to push straight through right over the top edge of that rib, and I'm going to kind of feel and almost hear it going through each layer until it finally pops. Okay, from here, I'm going to take my other hand and I'm going to help thread this catheter through. Okay, now we don't want to completely stab the needle all the way through the patient, because we don't want to stab any more holes into the lung. Okay, think of like an IV catheter. We're going to initially insert until we get a flash in the chamber, and then we just continue to advance that catheter. Same concept here. Okay, one additional thing I want to add: if we find our landmark, and then we're going to go ahead and start that low angle again, we're going to roll over the top, make that initial 90-degree puncture until you kind of feel it get into the pleural space. And then right there, we're going to want to kind of bring it back down, and we want to kind of direct the catheter towards the clavicle, okay? So we'll make our insertion there. And then as it's advancing, what it's going to do is kind of put that catheter in such an angle so when that lung starts to expand, it's going to hit the tip, and the tip continues to kind of run parallel now between the lung and that edge of the pleural space, okay? If we were to go at a complete 90 into the chest and that lung expands, there's a risk that it's going to go ahead and hit the tip of that and either plug it up, especially if we're only using that single hole at the tip, the original ARS needle, or as it tries to inflate more and press into that catheter, there's a risk that it could kink, and then obviously that's not going to work, okay? So again, we do a 90-degree insertion first, and then we bring that rotation down towards the hip just a touch, and we're going to direct the rest of that catheter towards that clavicle, okay? You're going to insert this catheter all the way to the hub where the plastic is, and then you're going to go ahead and remove the rest of that needle, okay? And then we just leave it there. I would recommend just leave it open. We don't have to put a valve on there. We don't have to put a stopcock on there. Just leave it open so air or blood can continue to come out. Now, hopefully your patient's going to start improving with signs and symptoms right away. The blood pressure is going to come up. That heart rate should come down. Anything else on the monitor, like your pulse ox, should increase, CO2 should increase. The overall presentation and anxiety of your patient should look a ton better if they're still conscious. If all that stuff starts to come back and your patient deteriorates again, we're going to have to do additional needles, okay? So as I always tell people in this training, if you use one needle, be very prepared to use a second needle, okay? They almost always will eventually clot or stop draining, and then you're gonna have to do more, okay? So make sure you have multiples prepared. If we're on the lateral side already and we do additional, now you wanna just come a little bit more lateral, and you're gonna continue to work your way posteriorly on that patient with whatever additional needles you need. In the critical care setting, my train of thought was always, if you do one needle, prepare for two, and if I do two needles, this patient really needs a chest tube. Like, stop messing around. Let's get them exactly what they need. For us on the streets with EMS, if you're doing multiple needles, you need to think about going potentially to the closest hospital, like, or do something where we can get that critical care to that patient faster. So in our world, it's going to be a matter of making a decision. Do we fly so we can bring a flight team onto the scene and they can do that chest tube? Or do we just need to load, go, and get to a doctor as fast as we can so they can make that insertion of a chest tube, okay? So next we'll talk about the anterior side and how we're going to insert there. This is just kind of demonstrating that lateral side. Now, typically, it is preferred that we use the lateral locations over the anterior locations. Again, it's going to help more blood drain if we have that tension hemothorax. Whereas if we were to needle on the anterior side on a hemothorax, you're not going to get much relief and any kind of drain of blood there. However, if you're on scene and you're able to move that arm out of the way, boom, you have access to laterals very easily. If you already have your patient packaged and he's all strapped up in C-spine straps and buckles on the gurney, and maybe you're already en route to the hospital in the back of the ambulance, I'm gonna go for what's easily accessible and the fastest way we can get a needle in that chest. So if they're all tied up like this, I'm not going to waste time undoing all those straps. I'm just going to go for what's available. Now, being a level 1 trauma, we should have this patient totally exposed already. So the anterior chest is real easy to just drop a needle in there, okay? Once you get that in place, then you can probably start working on removing some straps, try to get that arm elevated, and then we can go for a lateral position on any additional needles, okay? But when we go to the anterior chest, what we're gonna do is, again, find the total length of that clavicle from the suprasternal notch to the tip that leads into that shoulder. We're gonna find the medial location, and we're gonna roll our fingers over those ribs until we find that second or third intercostal space, okay? So there's my location. Again, gloved hands, I would clean it, and then I'm gonna grab my needle. So I'm going to come at a low angle again and roll over that rib, and then I'm gonna go ahead and puncture through my chest, okay? Trying to get over the top edge of my rib. So I feel it going through all those layers of the tissue. I feel it pop into that pleural cavity. Now I'm gonna stop my needle advancement and I'm gonna switch to advancing my catheter, okay? So I'm gonna go ahead and advance this hub of the catheter all the way into the skin. This mannequin is kind of shallow on this, but ideally I would want this plastic to be all the way towards the skin, and my needle then will come on out, okay? From here, we're gonna look and observe and assess for any signs of improvement, blood pressure coming up, heart rate coming down, airway is improving on the monitor as far as pulse ox and CO2. And now if I need to make additional insertions of additional needles, I'm gonna start working my way again towards the lateral edge, okay? So I'm moving towards the shoulder. Just go, pretty close to it. Right next, insert another one. Your patients are probably gonna go up and down. They're gonna make improvements with an insertion. A few minutes later, you're gonna see them start rapidly declining. So every couple minutes, again, have additional needles prepared. Always be monitoring your patient from a physical sense, as well as looking at the monitor, looking for any changes on the vital signs, okay? Be very quick to recognize these problems and jump on that additional needle. I would say it's not uncommon to drop 3, 4, 5, 6 needles for the length it takes us, especially to get to a hospital. One additional note I want to make, if we have a trauma code, specifically one that has thoracic trauma, okay, when they're coding, when we come up, we assess, unless there's an obvious side of the patient that's injured, that's obviously going to be the side we want to needle. But if they're just messed up all throughout, both sides look bruised, maybe there's crepitus all throughout, doesn't really matter about lung sounds at that point. If they're a trauma code with thoracic trauma, protocol is going to say just drop 2 needles, 1 each side bilaterally, okay? So 2 needles, boom, in. As you start ventilating your patient, assess for any kind of resistance or how that feels on your bag. Start looking at any kind of findings on the monitor, see if your pulse ox improves, if CO2 improves. Obviously, if it's a code, we're doing CPR. And then if there is any suspicion that it continues to have a problem, whether attention pneumo or hemo, then of course, we're gonna continue to drop additional needles. If we can come up through assessment that it's isolated to one side or the other, then obviously we'd focus on that side. But if we don't know, and they're not showing any other sign of improvement, just keep needling that chest. I'd say maybe every minute or 2, do an additional one, okay? Along with all your ACLS protocol stuff. So IVs, fluids, epi, airway, all that stuff in the appropriate order, all right? So that's attention pneumo and hemothorax with your needle decompression. As far as managing the airway goes with these trauma patients, let's say that they had some kind of penetrating wound or blunt trauma. Maybe you sealed some holes with occlusive dressings. Maybe you've dropped some needles, or not. Maybe you just show up, you find this patient is very anxious, declining rapidly, their blood pressure is low, heart rate's fast. All those signs and symptoms are there of a tension pneumo, especially for the BLS folks watching. We probably, as long as they're breathing, want to just give them O2 through maybe a high flow cannula and or a non-rebreather at 15 liters per minute, okay? If we start ventilating this patient right away and we don't have medics readily available to drop needles in here to release the pressure, it only takes a few breaths on a BVM with positive pressure to maybe take a simple pneumo and boom, tension it right away, okay? So really, as the BLS folks that are gonna be bagging, really pay attention to, again, that resistance, that compliance of that bag. And we probably don't wanna start bagging them unless we absolutely have to based on a rate, rhythm, quality, or until we get medics to show up and who can start dropping needles. Obviously, if your patient's not breathing or 2 out of the 3 rate, rhythm, quality are out of whack, you gotta go ahead and do something for them. So I would say at that point, start ventilating your patient. It's kind of like a double-edged sword. We wanna ventilate our patient, but just know without the ability to release that tension and that pressure, you have a potential for causing more of a problem and your patient's going to deteriorate rapidly. One more thing too, when we have a patient who starts off with pulses, a lot of times we're really good about managing all of our trauma stuff. However, being the type A people that we are, if we have some kind of combative, anxious patient, we really tend to want to just jump on them and strap them to a board, right? And then if they code, usually our focus is going to go directly to managing that code. So CPR, airway, IVs, epi, again, all the ACLS stuff. You have to remember your 5 H's, 5 T's. Remember why we're here. If this is a trauma patient and you're noticing crepitus, bruising, any kind of signs or symptoms that there's thoracic trauma, maybe they coded because of those 4 things that we talked about earlier: tension pneumo, tension hemo, pericardial tamponade, or massive hemorrhaging, okay? Well, we can do stuff for each of those in some sense, okay? So if you went from a live patient to a dead patient, again, our protocols for trauma codes are gonna say bilateral needles if they have thoracic trauma, okay? So don't forget to manage the needles and the decompression on top of all your other ACLS management for this trauma code. Now, those last 2 things that we talked about that could kill your thoracic trauma patient, being the pericardial tamponade or massive hemorrhaging. We used to be able to do a pericardial centesis to get into that pericardial sac and release the blood that might be surrounding the heart, causing Beck's triad. However, that's been out of our scope for quite a while. Your flight teams can still do that and your doctors can do that. So again, you have to make a decision. Do we bring the treatment on a helicopter to the scene? Obviously, we got to call early for that and do everything appropriately. Or we got to consider, where are we transporting this patient to? Okay, and then the other one being the massive hemorrhaging. Okay, there's not really a whole lot we can do for that, but for both of those, they're basically forms of shock. Either they're an obstructive shock with the pericardial tamponade, or they're a hemorrhagic shock, and they're running into hypovolemia. Okay, so with those 2 patients, it's basic shock management. So we're going to lay that patient supine, cover them with a blanket to keep them warm, high flow O2, and rapid transport to the appropriate closest facility, okay, being usually a level 1 trauma. Now, if we lose pulses or this patient has no airway and we don't have an ability to secure an advanced airway, whether an iGel or intubation, then again, I would not take my patient further to a level 1 trauma. If I just have a free standing ER and there's quite a few minutes or miles left to get to a trauma center, again, if you don't have ABCs, you go to the closest facility, period. There's doctors, there's nurses, they can do needles, they can do chest tubes, they can get the patient intubated, they can do all those things, hopefully stabilize your patient, and then they can transport them to that level 1, okay? Ideally, we would like to go to a level 1 so they can rush to surgery, get massive blood transfusions, all that stuff. But only if you know you have pulses and you know you have a definitive airway and you can manage this patient from point A to point B for whatever extended amount of time that is. One last thing I want to talk about, since we are talking about trauma management, if we have external bleeding, first thing we're going to do is apply direct pressure with a gloved hand. And then from there, we're going to have a partner grab us a tourniquet, apply the tourniquet, The book is going to tell you to go about 2 inches proximal to the wound, not on top of a joint. But most protocols, most field management now is going to be putting tourniquets high and tight. So if you have a bleed on your arm, we want to put the tourniquet up here closer to the shoulder. And if it's on the leg, we're going to bring it really high up into that thigh. The book will tell you if you need a second tourniquet to place that second one just above or proximal to that first tourniquet. However, if we've already gone high and tight, whether arm or leg, then we're going to add that additional tourniquet just below that first one, okay? Always make sure that we're cranking that thing down. It's going to be uncomfortable for you and the patient. It's going to require 2 hands to get that last turn in, and your patient's probably screaming in more pain than what they originally had with their wound. So it's going to take a lot of rapid communication from you to your patient, encouraging and ensuring them that you're doing this for a reason. You got to stop the bleeding. And then once you can save their life and prevent them from bleeding out, then we can give them some pain management, assuming their blood pressure is good and everything's appropriate. Maybe follow up with some fentanyl, maybe a low dose of ketamine if needed. We worry about saving their life first, stopping the bleed, then we make them comfortable. An additional thing we can add to this external bleeding is going to be using something such as the combat gauze, okay? So this is going to have a product that's in there that's basically going to help clot. Now we're going to have to insert this directly into the wound and try to apply it as close to the ruptured arteries as possible. So just reviewing this, there's several points on every side of this package that we can use to tear. So it doesn't matter how you grab it, you find one of those and we're just going to peel it off, okay? We're going to grab this bandage, and it's going to be packaged in this Z kind of pattern, okay? So you're going to just take a handful of it and you're going to use your other hand and kind of use your thumb and start packing that wound wherever that is in the extremities. And you want to get this as deep as you can. Ideally, it'll be directly against that bleeding artery, and just pack as much of this in there. And then you're going to apply a lot of pressure onto that. And I would grab some kind of Coban or cling or pressure bandage and wrap around that extremity with this inside the wound to cover it all up and just to apply a little bit more direct pressure to it, okay? So try not to rip it out and let it just fly everywhere. Don't let this fall into the ground. Keep it in one hand, and again, use your thumb to keep directing this into that wound. If we're trying to manage a patient who's lost a lot of blood and their blood pressure is low, we can do our IVs, we can give fluids, and just so you guys know, lactated ringers is usually more preferred than normal saline now in the trauma world. It just has a better pH balance for your patient. We have to be careful how much fluid we give though. I mean, do your large bore IVs, 2 of them, start running fluids in, but we're only gonna give them enough fluid to maintain peripheral pulses. So we'll check the pulses at the wrist. Pedal pulses work as well. If you feel that pulse, we can go ahead and slow down those IVs to a TKO. What we don't want to do is give them so much fluid that we shoot that blood pressure up and we start breaking up that newly formed clot inside their vessels, okay? Ideally, we want to have a blood pressure over 90, but again, in reality, we're really looking for those peripheral pulses, and we want to try to maintain a map over 65. If your patient's going to require an airway such as an I-gel or intubation, again, I would recommend that we keep them on high flow O2 until we have the ability to drop some needles to release any tension off of a pneumo or a hemo. Again, if the patient's not breathing, then you kind of have to get your definitive airways. But if we can hold off for a minute, if we find the signs and symptoms, stab them with some needles, release that pressure, then proceed with your definitive airways such as an I-gel or intubation. Because again, if you have no way to release that tension or the pressure, once you start giving them a couple breaths, it's going to create a massive tension, and then your patient's going to deteriorate rapidly, okay? But again, that's for a patient that might be breathing on their own, just a little rapid and shallow. Support that the best you can with high flow O2 first. Then once we can needle, start ventilating your patient. As a quick wrap up and summary, if you have any kind of penetrating wound from the neck to the pelvis, we're going to put an occlusive dressing on that. If we have any kind of blunt trauma, such as a flail segment, we want to do positive pressure ventilation. If you have somebody that has signs and symptoms with Beck's triad or pericardial tamponade or any other massive hemorrhaging that might be internal, we're just going to do basic shock management. Again, lay them supine, cover with a blanket, high flow O2, rapid transport. If we need to manage blood pressures, we can do IVs. We can give some fluid to maintain peripheral pulses. Remember, we prefer to use LR versus saline because of the pH. If we have to give some push dose epi to keep the map up and support that blood pressure, feel free to do so. Remember, push dose epi will be about every 2 minutes. You're going to continue those doses. And if we have any massive external bleeding, apply pressure, put a tourniquet on them, treat for any signs of shock, and as always, rapid transport. Well, there you have it, guys. I appreciate you guys checking out my video. Don't forget to subscribe, hit the bell, all the things for YouTube. If you guys want to watch additional videos, Medic Junkies is the name of our channel. And for those of you on my department, go through your equipment and make sure you have all this newer, updated stuff. We all should have the combat gauze, but just double check that you have it. We should have the enhanced ARS needles, okay? Should have multiples of those. And now we should be carrying these hyphen occlusive dressings, the hyphen vent. Okay, so check out your gear, make sure you have these. They should be in your trauma box. You should also have additional in both active shooter bags. So if you guys have any questions, feel free to reach out. Until then, thanks guys.